Today we're going to talk about non-traumatic spinal cord injury. So this is a huge topic. It traditionally used to be a 2-hour lecture, and we have whittled down to 1 hour. So bear with me. We're going to be going over a lot of things. I'm going to try to keep it pertinent to focusing more time on some of the more common diagnoses and a little bit less time on some of the things that are less commonly seen, both for clinical relevance, and then also the same patterning will kind of fall as far as things that are relevant for board questioning, things like that. So it's hard to make kind of global comments or comparisons. As I said, non-traumatic spinal cord injury is a huge topic. However, just overall, compared with traumatic spinal cord injury, there's more common to have incomplete lesions, and so less severe neurologic impairment in general. Also a lower incidence of secondary medical complications during rehab. Again, just looking at this as a global category, that may be different for some of the more specific subcategories. In general, non-traumatic spinal cord injury tends to have shorter inpatient rehab length of stay as compared with traumatic. However, there's less consistent data reporting, compared with especially the model systems that we have for traumatic injuries. And as such, you tend to have kind of less ability to predict amount and rate of recovery due to, again, decreased consistency in data reporting, as well as just large variation in disease processes. So this is kind of an outline of the different types of non-traumatic spinal cord injury or spinal cord dysfunction, you may hear it called, that we're going to review. I kind of generally have this ordered into more common processes, kind of filtering down to less common. So we'll spend a little more time on these initial categories and a little bit less moving forward. So degenerative disease is by far the most common cause of non-traumatic and really of spinal cord dysfunction in general. So I think of it really in kind of as far as things that are going to affect the central canal, two main processes, spinal stenosis or spondylosis, and intervertebral disc herniation. So stenosis is typically going to occur in the lower portions of the cervical and lumbar spine. These being the more mobile portions of the spine. We'll talk a little bit more about the pathophysiology in the upcoming slides, but essentially when you have that degenerative arthritis, you end up with kind of a dynamic component to compression of the spinal cord due to that mobility. And for that reason, this is more rare in the thoracic spine as there's less mobility in this area. We will see thoracic myelopathy due to stenosis, I think more commonly in people who have some etiology of congenital spinal stenosis. And then disc herniation, you guys are all familiar with. That also is going to most commonly occur in the lower portions of the lumbar and cervical spine. So spondylosis is process usually starts with loss of water in the discs, and then as a result, there will be decrease in the disc space and decreased laxity of the annulus fibrosis, which ultimately leads to a disc bulge. That can result in destabilization of the posterior joints, ending up with bone proliferation, osteophyte formation, and ultimately protrusion into the spinal and nerve root canals of these things. So in the cervical spine, you're typically going to see patients with this present initially with changes in gait or balance, and that can really be the presenting feature, is starting to have some gait dysfunction. They can have pain, usually in the neck or radiating to the arms. In later stages or as it progresses, you may see the patients with loss of manual dexterity, complaining of dropping objects. They often will have upper motor neuron signs, so you may see a positive Hoffman's or Babinski reflex, hyperreflexia in general. Sensory abnormalities, most commonly loss of proprioception and vibration sense, and bladder dysfunction is typically going to be urinary frequency or urgency if it exists, and less commonly incontinence. They may have some incontinence in the setting of urgency, but not really gross incontinence. So cervical stenosis in general is extremely common, and some degree of age-related spondylosis is essentially universal. It's one of the more common indications for C-spine surgery, accounting for about 20% of all C-spine surgeries done in this country, and is considered the most common cause of spinal cord dysfunction. It's also the most common cause of gait dysfunction in persons over age 55, which I think this particular point is important to remember. Like I said, a lot of these people, the initial presentation is going to be balance deficits or gait dysfunction. And believe it or not, while this is the most common cause, I see people who have had this missed a lot in the early stages. They get workups for peripheral neuropathy, other things. They get brain MRIs, and they don't get their neck looked at until a little bit later on. So I think it's just important. These people are going to present to all different types of outpatient settings, and so most of you are going to end up seeing them regardless of your chosen subspecialty down the line. So I think it's just important to keep this on the radar when people present with ambulatory dysfunction. So when you see someone with this kind of the typical evaluation and treatment, again, kind of focusing on getting, looking for some of the information we just discussed in the history and physical exam. Imaging, MRI is going to be the modality of choice. If they've had x-rays, you may be able to see loss of lordosis, osteophyte formation, etc. on plain films, but really getting the MRI to evaluate, for areas of impingement and any compromise to the central canal is going to be the modality of choice. In terms of treatment, if disease is mild, so both in terms of the degree of canal stenosis on imaging as well as the patient symptomatology, it's typically going to be more conservative, maybe getting them into a therapy program to work on balance, what things they may need for pain control if that's an issue. However, if they have more severe symptoms and or usually going along with a more significant degree of central canal compromise on imaging, you're typically going to require surgical intervention. C-spine surgery can be done from a ventral or dorsal approach, or sometimes a combined approach depending on the number of levels involved and the degree of intervention pursued. In general, the goal of surgical intervention for this indication is to prevent progression or prevent worsening, which is important to kind of educate the patients on that. While about 2/3 of people do have some degree of improvement after the surgery, really the primary goal of this surgery is to prevent any worsening of their disease process and symptomatology, not necessarily to create any improvement as some of the cord compromise has already occurred. So moving down into the lumbar spine, presenting features of lumbar spinal stenosis is commonly going to be pain and that kind of classic description of neurogenic claudication. So pain, pain in the lower extremities. They may progress to lower extremity weakness, bowel and bladder incontinence, and again, more incontinence here compared with in the C-spine due to the more lower motor neuron involvement of the cauda equina in this area. And they're typically, as kind of things progress, will have symptomatic periods alternating with asymptomatic periods. Again, treatment is going to be based on the degree of, severity of the symptoms and, compromise seen on imaging. But again, for severe and progressive deficit, surgical intervention is warranted. A lot of people who primarily have pain or some mild weakness will kind of live with some degree of deficit related to this and, just continue to be monitored. So disc herniation, compared with the stenosis and myelopathy, which it tends to be a little more progressive, this can occur with a sudden onset presentation, but can also be gradual progressive. The most common disc herniations are typically dorsolateral in direction, which end up impinging the nerve root canal and causing radiculopathy, usually just 1 or 2 levels. So we're not really going to talk about that today because we're here to talk about the spinal cord. So in the less common instance, you can actually have the disc have a midline herniation, and if that occurs or you end up with disruption of the posterior longitudinal ligament due to a large disc herniation, that's when you can end up with cord or cauda equina compression. Usually the presenting symptom is going to be moderate to severe pain right at the site of the herniation. If this occurs in the cervical or thoracic spine, you may see an anterior cord or a total cord syndrome. And if it occurs in the cauda equina area in the lumbar spine, you'll of course see more of a cauda equina syndrome. Management, again, if it's more mild, you'll be looking at surgery, possible epidural injections for pain management, etc. If the presenting symptoms or progressive symptoms are severe, then you'll end up with a surgical intervention, usually a discectomy. In cases of cord compression, about 50% of patients will have improvement with surgery. In cases of cauda equina syndrome due to a disc herniation, most patients will recover some degree of sensory and motor function, and about a third will have residual bladder dysfunction. So we're going to shift from degenerative disease into tumors. Does anyone have questions about the degenerative disease portion before I move on? All right, we'll keep going. So tumors of the spine or spinal cord are divided into 3 categories: extradural, which are outside the dura; intradural extramedullary, which are inside the dura but outside the cord; and intramedullary, which are within the cord itself. So extradural will be the most common, comprising about 55% of spinal tumors. The majority of these are metastatic. Looking at the intradural extramedullary, those comprise about 40% of tumors. And there'll be a mix of metastases and primary spine tumors. We'll talk a little bit more about the most common presentations of that. And then intramedullary are significantly more rare, only about 5% of spinal tumors within the cord itself. So with extradural tumor, back pain is the most common presenting symptom. Up to 95% will present with back pain, usually progressive local pain. Some may have radicular pain. Some may have some myelopathic findings. And usually the pain will be increased in supine positioning. As I said, the majority of these tumors are metastatic, lung, breast, prostate, to name a few that most commonly occur. This image is from one of my patients currently on the unit with metastatic renal cell carcinoma. And typically the METs will occur due to hematogenic spread or via direct extension. And the vertebral bodies are most commonly involved, then progressing into kind of tumor, then starting to encroach on the cord. And this type of metastatic disease most commonly occurs in the thoracic spine. You can get some types of primary tumors in this area as well, with the most common being multiple myeloma. You can also develop vertebral hemangiomas, which are benign in nature, but may result in cord compromise as well. The damage to the spinal cord is typically caused by compression due to impingement from the tumor or collapse of bony structures, or both. More rarely, you can also end up with cord damage due to ischemia if venous drainage is significantly occluded by tumor burden. And the treatment is really going to be dependent on the severity of symptoms, cord involvement, as well as maybe prognosis dependent. So It can vary from steroids, radiation, surgery, one or a combination of all of those things. So the next category, intradural extramedullary. Again, these are also going to present primarily with pain, more common to have some progressive radicular pain and paresthesias. Primary tumors that will occur in this area, you'll have two types of nerve sheath tumors, most commonly, so neurofibromas associated with neurofibromatosis type 1. That results in enlargement of nerve ventral roots, most commonly occurs in the C-spine. This is a neurofibroma in this picture. Schwannomas occur on the outer surface and create mass effect. They more commonly occur in the dorsal roots and more commonly in the thoracic spine. Patients with schwannoma will typically present with spastic paraparesis. And both of these tumors tend to be non-malignant, with schwannoma about less than 1% transforming to malignancy. You can also have meningioma in this area, which is the most common primary CNS tumor. They arise from arachnoid cap cells in the dura. They're most common occurring in females in the 5th to 7th decades. And nearly all of them are solitary, meaning the patients don't really have a risk of recurrence or other tumor burden in the CNS. It's rare to have METs in this location. If you do, it's typically hematogenous spread or direct extension from the CSF. This is where you'll see drop METs from brain tumors, which tend to be associated with a poor prognosis. Lung, prostate, and breast, as mentioned on the previous slide, do tend to metastasize more to the extradural space, but you can get metastases within the dura from those. And again, usually that's more due to people who already have brain involvement and then having drop METs into the CSF. So intramedullary tumors, again, metastases are less common here, and most commonly within this category, you'll see primary tumors. Of those, the two main categories being ependymoma and astrocytoma. The ependymomas are a solitary tumor arising from the ependymal cells, and usually you're going to see diffuse enlargement of the cord over several levels, as pictured here. They will occur most commonly either in the C-spine or the filum terminale of the L-spine. Greater than 50% will be associated with serous. Really, both of these types of tumors can be commonly associated with cysts within the spinal cord, and if there is a cyst present, either serous or blood-filled cyst, it tends to be associated with a poorer prognosis. In general, ependymomas are fairly easily excised, and the prognosis is fairly good. Astrocytomas, however, are malignant. These more commonly occur in children. C-spine and T-spine being the most common involved, tend to come with a more asymmetric presentation, maybe unilateral findings, and the resection is often difficult and piecemeal with associated a poorer prognosis due to that. All right, we're going to move out of tumors into vascular conditions. So before we talk about kind of the main vascular conditions affecting the spinal cord, infarct, AVMs, and hemorrhage, just need to briefly review the blood supply to the cord. So the anterior spinal artery supplies the anterior 2/3 of the cord, and then there are two posterior spinal artery which supply the remainder. All of these arise from the vertebral arteries in the neck and run the length of the spinal cord. And the vasculature in general at the level of the conus forms an anastomotic network that encircles the cord. At each segmental level, you'll have smaller branches of radicular arteries, and then the kind of most commonly involved, or the artery that you're gonna see cited as an etiology in some of these things is one large radicular artery in the lower thoracic and lumbar region, the artery of Adamkiewicz. This is typically arising between T9 and L2, and just kind of this structure with blood being supplied by this one large radicular artery in that area leads to a watershed area in the upper and mid thoracic level. So those are kind of where you're often going to see issues with infarction in that watershed area. So spinal cord infarct is fairly rare compared with brain infarction. So you will hear this described as spinal cord stroke, and as you know, that's really the etiology, however much more rarely seen than involvement in the brain. Usually you can present with infarction, you can have a presentation of anterior cord, posterior cord, or Brown-Séquard syndromes, with anterior cord syndrome being kind of the most common true cord syndrome presentation of infarct. Mechanisms, sometimes it's unclear, but often it's associated with profound hypotension, such as in the case of a cardiac arrest or massive hemorrhage. And again, the watershed areas being most vulnerable in that situation. Aortic surgery itself, so the incidence of paraplegia after resection of an aortic aneurysm ranges about 5 to 6%. The exact mechanism of this in relation to aortic surgery is not clear. Thought likely hypotension due to cross clamping of the aorta. And it's thought that the endovascular approach has less risk than an open procedure, but overall still a 5 to 6 or 7% rate of paraplegia after aortic surgery. And so that is something that I think you do see from time to time on the spinal cord unit here. Can also end up with infarct due to embolism. The most common source of that is going to be fibrocartilaginous material from the discs. Usually originates from Schmorl nodes and will then progress to the cord via the basicentral vein of the vertebral body. This process occurs most often in the cervical region. And then you can also have venous infarction, which is even more rare, and that will occur due to occlusion of the venous drainage of the cord. When this does occur, it tends to be extensive. Has been associated with extensive DVT in the common femoral and internal iliac veins. And then other predisposing conditions for this would be chronic infection, polycythemia vera, ulcerative colitis, and pancreatic cancer have been associated with venous infarct of the cord. So spinal AVM is basically when there's a fistula between the artery supplying and the vein draining the cord. And this results in shunting of high pressure blood into the veins, which then results in dilatation and elongation of the venous system, this kind of tangle of vessels within the cord. And so pathology of the cord is due to increased venous pressure from the AVM. That's going to be classically described as this French name that I can never pronounce super well, Foix-Alajoinine syndrome. So you may hear people call it that, which just refers to the presence of a spinal AVM with neurologic deterioration due to this venous congestion or venous hypertension. There are 4 types of AVM, with 1 and 2 being more common, 1 being the most common. Type 1 is in the dural space, typically occurring in the dorsal aspect of the lower thoracic cord and conus, and type 2 being intramedullary. Type 3 is a type of juvenile malformation, and it involves the spinal cord parenchyma, and 4 is intradural extramedullary. Both of those are more rare. Typically, the symptom presentation will be a more gradual onset of neurologic deficit, and these are best evaluated by angiography. This is a situation where there is some potential for improvement, even if the patient presents with a total cord syndrome. There is a potential for improvement with treatment of the AVM, either surgical obliteration or endovascular embolization. So this is an important part of the workup for people who present with concern for AVM, as intervention may actually reverse the neurologic deficit or give some degree of improvement. Intraspinal hemorrhage. 60% of hemorrhages occur with an unknown etiology. About a quarter of them are associated with anticoagulation or another coagulopathy. 5% associated with a vascular malformation or tumor, and about 10% are due to trauma. Hemorrhage can occur in the epidural space, subdural, subarachnoid, or into the cord itself. Typically, the patients will present with pain at the site of the bleed, so back or neck pain, and then weakness and sensory loss to varying degrees depending on the degree of compression and amount of size of the hematoma. Imaging can be evaluated with CT or MRI, and typically will be seen as a mass compressing the spinal cord. A subarachnoid hemorrhage will not compress the cord, as the blood will spread throughout the CSF, and the treatment is really emergent surgical removal of the hematoma. So that concludes the vascular etiology portion of the lecture. So the next kind of main category is infection affecting the spinal cord. And there is a whole host of different infections that can affect the cord. Again, kind of similar to the overall lecture, I'm going to try to focus on the more clinically relevant ones. So this chart kind of divides infection etiologies into the typical location within the spinal canal, and then the etiologies. So some of these I'm going to talk about in more detail in later slides, but looking down at this kind of bottom section of the chart, these occur more rarely, but things that we should be aware of. So when the actual cord parenchyma is involved by infection, some things on the differential can include viral infectious transverse myelitis, HTLV1 myelopathy, HIV vacuolar myelopathy, and CMV, which is also associated with HIV. So both of these tend to occur in the late stages of HIV/AIDS, persons with a CD4 count less than 200. HIV vacuolar myelopathy will primarily affect the lateral and dorsal columns of the cord. CMV usually presents more as a rapidly ascending polyradiculopathy, and classically involving the cauda equina. Both of those have a pretty poor prognosis and high mortality rate. Epidural abscess is more commonly seen, and that can occur by hematogenous spread, by local extension from osteomyelitis or discitis, or from direct inoculation, either via trauma or iatrogenic related to a surgical procedure. So typically the presentation will be back pain, fever, weakness. The majority of patients do not have all three symptoms. Weakness, when it occurs, will typically be in the legs, and weakness is bilateral in about half of cases. Sensory and bladder symptoms are less common with an epidural abscess, and usually the symptoms will be progressive over a few days to weeks. Symptoms have been present for more than 2 weeks before diagnosis in greater than 2/3 of cases, so this can be a really insidious process. In terms of evaluation, of course, MRI is going to be preferred, using gadolinium to try to evaluate the abscess itself. You may also see, obviously, things you're going to look for in serum studies, so Leukocytosis occurs in only 40% though, so a normal white count does not rule this out. And then you can have an elevated SED rate in CRP, which of course is nonspecific. The outcome will depend largely on the degree of deficits and how long the deficits have been progressive prior to intervention, with usually surgical resection of the abscess being required, in addition to antibiotics. So if someone has complete paraplegia for over 36 to 48 hours prior to diagnosis or intervention, typically you're not going to see a significant amount of recovery. So similarly, vertebral osteomyelitis or discitis can again occur due to hematogenous spread, contiguous involvement, or direct inoculation. The most common pathogens are going to be Staphylococcus species, with some other more common pathogens associated with specific disease processes. So Salmonella in persons with sickle cell anemia, gram-negatives and people with immunocompromised. And in IV drug use, still staph is very common, but there's a higher incidence of Pseudomonas infection among people with an IV drug use history. So again, evaluation is going to be initially with MRI, and really the gold standard for osteomyelitis is going to be having a biopsy to diagnose and to help guide treatment. So that can be done with CT guidance or with direct surgical sample if surgery is pursued. All of these people will get antibiotics, of course, and then surgical intervention will depend on the presenting features and patient characteristics, if there's spinal canal compromise, if the patient's having neurologic deficits, etc. So post-op infection, kind of talk about in a separate category, but really this can involve osteomyelitis, discitis, as well as epidural abscess, as we just discussed in the previous slides. But the incidence of infection in general is about 1 to 2% after laminectomy and discectomy, and it increases up to 12% in patients who received instrumentation in the spine. Risk factors related to the surgery itself: long implant constructs, a longer surgery, use of an operating microscope, and increased blood loss during the surgery will give an increased risk for post-op infection. Patient factors: poor nutrition, already immune compromised, obesity, age, smoking, diabetes, and having a spinal cord injury. So all things that you might kind of think would lead to an increased risk of infection. Usually the presentation again will be increased pain. They may have new neurologic changes, fevers, chills, or incision changes. However, if you have a deep infection and a tight fascial closure, you can have progression of an infection in the surgical bed deep to the incision with a fairly normal or good-looking incision. So looking good on the surface does not necessarily rule out a post-op infection. Evaluation is going to be similar to the previous MRI imaging, although it can be difficult to differentiate post-op changes from new infection. Lab work and really just kind of clinical presentation of the patient overall. Treatment, again, will kind of depend on the degree of involvement. In general, antibiotics of some degree will be appropriate. They may require IND or serial irrigations and washout and packing. In general, the general wisdom is if the patient has well-fixed hardware to try to leave it in place. But if someone has issues with really serial or progressive infection, then sometimes they have to progress to hardware removal and replacement. So arachnoiditis also falls in the category of infection. This is more rare than the others we just discussed, but it can be seen. This image is actually from one of my patients I had on the unit a couple years ago. So, if I have an image from my own patient, it's not that rare. The process is irritation or inflammation in the subarachnoid space that leads to basically this scarring, tissue proliferation. You get thickening of the arachnoid material and adhesion formation. So the nerve roots and or the cord are then compressed by these tissue bands or by associated loculated CSF. The typical causes of this will be iatrogenic, having had some kind of intervention into this space. So use of intrathecal contrast during a myelogram has been associated. Intrathecal or epidural anesthetic agents as used with injections or irritation of the subarachnoid space during surgery. On MRI, you're going to see kind of diffuse abnormal T2 enhancement along the involved areas, and this is most commonly going to occur in the conus and cauda equina area, kind of as you can see all this kind of diffuse T2 signal abnormality on this image here. The patients are usually going to have, can have a really severe degree of pain both at the site of the arachnoiditis, usually in the low back, as well as radicular pain down the legs. They may also then have sensory loss and weakness in the lower extremities. There's really not a reversible treatment. Symptom control to whatever degree is necessary, rehabilitation, surgical resection of the arachnoiditis has not proven to be beneficial. So kind of leaving infections into our next category, inflammatory or autoimmune myelopathies. So the main categories of this are going to be transverse myelitis, NMO, and multiple sclerosis. I wanted to mention MS in this slide just because it kind of is in the continuum with these other processes, and sometimes, you know, they're all usually considered in the differential together. But you'll have a whole separate lecture on MS, so I'm not going to talk about it any further in this lecture. Transverse myelitis is an acute intrinsic inflammation of the spinal cord and usually will involve the entire cross-section of the cord and result in a total cord syndrome with you'll usually see a horizontal level in imaging. As such, you know, the symptoms are usually symmetric, and this most commonly is going to occur in the thoracic cord. NMO is a similar process with associated also inflammation of the optic nerves, and typically in comparison with transverse myelitis, the lesions will be more longitudinal, involving 3 or more spinal segments. So transverse myelitis, again, presents with pretty much acute onset sensory and motor loss, paraplegia below the level of the lesion. The etiology is really not clear. It's thought to have autoimmune involvement. Often presents para-infectious with people having had a preceding viral syndrome or associated with a vaccine. May be associated with collagen vascular disease. Also may be the presenting feature of multiple sclerosis. On MRI, you're going to see a hyperintense T2 signal abnormality, and usually some degree of kind of cord enlargement, or it looks kind of like a cord edema. So you can kind of appreciate that in this image here, how the cord is enlarged. You see less CSF on either side of it. You're also going to be doing, you know, a number of serum and CSF studies to evaluate for other etiologies or systemic disease primarily. Usually you'll see kind of a pleocytosis in the CSF with transverse myelitis. Treatment can be steroids, IVIG, plasma exchange, some combination of all of those. Prognosis in transverse myelitis kind of follows this rule of thirds. So about a third of patients will have complete recovery, about a third will have no neurologic improvement, and then a third will be somewhere in the middle with some recovery, but having some degree of residual deficit. And about 5 to 10% of transverse myelitis cases actually end up to be the presenting feature of multiple sclerosis. Features associated with the transverse myelitis that make it more likely to progress to MS would be asymmetrical clinical findings, a shorter segment MRI lesion, so less than 2 spinal segments, and a more incomplete neurologic picture. So neuromyelitis optica, NMO, also has been called Devick's disease. This is an immune-mediated process. There's actually a detectable serum autoantibody that can be tested for this. As I mentioned in the previous slide, the MRI lesions tend to be more longitudinal, several spinal segments involved. It's clinically more severe compared with multiple sclerosis. Your CSF will have neutrophilic pleocytosis. And in comparison with MS, you'll have no oligoclonal bands, so that's kind of another way to differentiate it. But typically, you're going to be evaluating for NMO by looking for the serum antibody. Treatment is going to be steroids, plasma exchange. There's some evidence for immune suppression. So these are the patients that will be getting kind of monthly treatments or infusions compared with transverse myelitis, which is usually just kind of a 1 or 2 time treatment, as this can be a more progressive process. All right, we are moving right along. So the next category is nutritional myelopathies. I'm going to divide this into deficiencies and then into more toxic myelopathy secondary to ingested substances. So in the nutritional category, the kind of 3 main ones that we think about are B12 deficiency. I think this is one of the most commonly recognized or looked for, vitamin E deficiency, and copper deficiency. All of them tend to involve the posterior columns of the spinal cord most significantly. B12 deficiency, usually etiologies are going to be pernicious anemia with inability to actually absorb B12 if this is undiagnosed or untreated, of course. Patients with gastric or ileal resection or some other reason for malabsorption. It's pretty difficult to get this degree of B12 deficiency purely with poor dietary intake, just due to the small amount of B12 actually needed to maintain our stores. So usually it's someone with an actual reason for malabsorption rather than just poor dietary intake. Usually present with sensory abnormalities in the lower extremities, weakness, unsteady gait. Typically it will have diminished reflexes, as there's also peripheral nerve involvement. Other things you may see associated, so you'll see the megaloblastic anemia, obviously a low serum B12. You may see high serum homocysteine and MMA, as these are kind of the B12 binders. On MRI, you'll see T2 hyperintensity in the posterior columns. The treatment is going to be intramuscular B12 repletion. With vitamin E deficiency, again, usually etiology is going to be some type of malabsorption syndrome, and can also occur in patients with severe liver disease with cholestasis, since vitamin E is fat soluble if you have abnormality in kind of that process. So they'll present with more of a sensory ataxia, usually absent reflexes and lower extremity weakness. And really just the evaluation is going to be looking at vitamin E level and repletion when found to be low. Copper deficiency, this is absorbed in the stomach, so most commonly you'll see deficiency in patients who have had a large gastric resection or bypass. Again, presents with ataxia, gait unsteadiness, paresthesias. Compared with the other 2, you may see actually upper motor neuron signs. The patient may also have associated anemia and leukopenia, and usually you're going to do parenteral and then oral copper repletion. So toxic myelopathies, these are more common in other countries. So lacerism being associated with ingestion of chickling peas. And this is when this particular substance is used as a third to half of the diet for greater than 2 months. So it's typically, populations vulnerable to this are persons that live in areas of, flood, famine, war with unstable or unsteady kind of food stores, and resort to the use of these chickling peas as a primary component of diet. Typically will present with the spastic gait, sphincter dysfunction, and deficits are usually permanent. There's not really any treatment. Conzo is kind of a similar process. This is associated with cyanogen ingestion related to manioc or cassava root. This occurs most commonly in African countries where those things may be used as a food source. Again, usually kind of gait disturbance and upper motor neuron signs, and again, really not any reversible treatment. So collagen vascular disease, looking at lupus, Sjogren's, and sarcoidosis. As far as involvement of the spinal cord in lupus, it's not the most common presenting feature, but it's also not necessarily rare to have some degree of central nervous system or spinal cord involvement with lupus. And typically what occurs is there will be vascular changes within the cord that lead to myelomalacia, necrosis, or cord infarction. So the presenting features will be paraparesis, numbness, bladder dysfunction. And typically the deficits are pretty severe. You can use steroids for this, though really not thought to have too much effect, and usually the outcome neurologically is pretty poor when this occurs. In Sjogren's, actually about 20% of persons with Sjogren's syndrome will have CNS disease. It can be multifocal, and the cord is usually involved. So again, they'll have paraparesis and bladder dysfunction. It can be more of a relapsing remitting course, and this can be treated with steroids, plasma exchange, or disease modifying agents, some combination of all of those things. Sarcoidosis, on the other hand, is pretty rare to have associated neurologic involvement. About 5% of people with sarcoidosis have neurologic involvement, and of those, only 1% has spinal cord involvement. When it does occur, it'll be progressive paraparesis or quadriparesis, with the C-spine being most commonly involved. About 75% will improve with steroids. You can also surgically resect the lesion, although there's a risk of neurologic deterioration with that as well. And so then the kind of global category of hereditary myelopathies, there are others, but these are kind of ones that may be more commonly seen. So hereditary spastic paraplegia, there are actually multiple forms of it, but most often is an autosomal dominant inheritance pattern. And the onset will be typically between 10 and 30 years of age, and present with gait instability and lower extremity spasticity. Typically there's minimal weakness, and spasticity is really the main issue. It's pretty slowly progressive, and most patients are able to remain ambulatory to some degree. Treatment is really just supportive and symptomatic. You do see these people coming into spasticity clinic, and there are a few within our baclofen pump population here, which is a pretty decent treatment for persons with this diagnosis. Friedreich's ataxia is an autosomal recessive inheritance pattern. It's due to a triplet repeat. It is essentially spinocerebellar degeneration. Symptom onset is typically in late childhood or adolescence, and can include loss of position and vibration sense and ataxic movements. Dysarthria, emotional ability is also associated. They also have associated cardiac disease, cardiomyopathy, and usually will have kind of decreased life expectancy due to that. Most of patients with Friedreich's ataxia will progress to loss of ambulation and use of a wheelchair, usually within 10 to 15 years of symptom onset. And so lastly, kind of just a category of other, meaning that these etiologies don't fall into any of the other categories previously discussed. Radiation myelopathy is white matter damage to the spinal cord that occurs as a result of radiation exposure. It can occur divided kind of into early and late. So early being within 6 weeks to 6 months after radiation exposure. And that will typically be associated with shock-like pain, numbness, paresthesias. The late type of radiation myelopathy can occur greater than 6 months and up to 4 years after radiation exposure. This is more rare, thankfully, but also more serious and severe. So can present more with almost like a total cord syndrome, weakness and sensory loss below the level of cord involvement, the level of radiation exposure. The treatment, usually you will give steroids for cord edema, but improvement is pretty minimal even with the steroids. So it's a pretty poor neurologic prognosis. Can also have myelopathy due to induced electric shock due to exposure to a high voltage current or a lightning strike. The symptoms can actually occur days to weeks after the event, with actually 1 week after exposure being the most common time to present with neurologic symptoms, and typically will be a progressive paraparesis or tetraparesis. And then decompression myelopathy or the bends, so related to pressure shifts due to rapid return to surface after deep underwater activity. So that would be usually progressive paresthesias and numbness in the limbs, also associated with nausea, vertigo, and ataxia. Treatment is recompression therapy. So if cases are mild to moderate, recompression is pretty successful in reversing deficits, but in severe cases, less so. This is radiation myelitis. You can see kind of the T2 signal change and cord edema here.